everyone. On behalf of Eldorado Biotech, I, Dr. Sailesh Rikadkar, Senior Medical Manager, welcome you all on this platform of mission of Migraine Free India. Being a pharma company, and we feel that it is our social responsibility to assist the medical fraternity in unique ways, and this Meet the Expert Migraine Free India is one of it. Migraine, as you all know, that it is a unilateral headache that causes a throbbing pain and pulsating sensation. And apparently, a very simple looking definition is not enough, or not even a tip of an iceberg of what exactly the pain is, experienced by the migraine sufferers. So the reason behind this is the increasing prevalence nowadays, lifestyle changes, uncertainty of attacks, overall quality of life, and everything. These are the problems which are being faced by today's generation. And specifically when it comes to the tropical countries like India, exposure to sun and sleep deprivations and many other factors are nowadays creating issues for this problem. So unfortunately, the lack of definite tools, or we can say the lack of awareness of this disease and resulting into the delay in the treatment is causing the increase in the density of this migraine headache attacks and migraine burden on India. So basically, as you all know, that migraine is different in different individuals. So every patient will not have a headache, but some may have a significant headache as well. So some people may go through some different type of issues, like someone for abdominal discomfort or some refractory issues as well. So amongst all this type, the most untouched part of migraine type is the vestibular migraine. So yes, people do suffer with vestibular migraine, commonly known as migrainous vertigo or vertiginous migraine, or migraine-related dizziness, etc., etc., etc. But the complex nature of this vestibular migraine basically made us think of what is the reason and why this is happening, and why this is always said that it is untouched part. So we are really fortunate today to have an authority duo to discuss on this topic. And I'm very fortunate that we have excellent experts for this. I will just introduce to our first expert. Let us know our first faculty. Our first expert is Dr. Ketaki Patwardhan DM Neuro. Dr. Ketaki is a renowned neurologist and is eminent academician. She is working since last 15 years in the field of medical sciences, and she is relentlessly working for the betterment of society. It is said that relationship between a heart and a brain is very complicated, but I think Dr. Ketaki has successfully handled this both vital organs very well during her thesis work as well. Apart from this, she is a gold medalist and also has a keen interest in sports activities as well. She has many papers. She has published many papers in a many renowned publication and is honored with many awards as well in the field of medicine and neurology. And such a versatile personality, and she's also a member of Indian Academy of Neurology, Maharashtra Association of Neurology, and many such institutions. I welcome Dr. Ketaki ma'am on this platform.
Thanks for the kind introduction.
Right, thanks ma'am. The second very expert is Honorable Consultant ENT Dr. Rahul Gosavi sir. His very presence brings us a type of Sanjeevani, which means inspiration wherever he goes. So Dr. Rahul sir is relentlessly working for around 15 years in the medical fraternity, and Dr. Rahul sir has basically completed his MBBS from very prestigious college KG Somaiya, and his post graduation from Sanjeevani Medical Foundation. Dr. Rahul sir is an honorable member of Trustee Board, Deputy Director and member of Governing Council of Sanjeevan Medical Foundations, ENT PG Institute and Sri Siddhivinayak Ganpati Cancer Hospital, Meerut. And with many publications to his name, Dr. Rahul sir has recently worked as an honorary consultant on mucormycosis task force panel discussion and has presented many publications and many talks in various conferences. I welcome Dr. Rahul sir on this platform. We are very fortunate to have this duo expert for this today's talk. I welcome you, Dr. Rahul. So very first question to Dr. Rahul sir. So what is vestibular migraine from a perspective of an ENT?
Thank you very much for the kind introduction and inviting me to this talk. Honestly speaking, as an ENT surgeon, vestibular migraine is a slightly neglected topic. That's what I will say. But I think we'll just, with the point of having this discussion, is basically to understand the disease, the concept, and the management. So, migraine per se, if you ask a lay person, it is called as a sick headache or a sickness headache. And migraine, as you already said in the introduction, basically it's a unilateral headache of mostly unknown etiology, and it's a diagnosis of exclusion. When you exclude all the other etiologies, that is when you come to a diagnosis of migraine in most of the cases. Now, if this migraine is coupled or associated with any of the vestibular symptoms, which are mostly include any form of giddiness, vertigo, tinnitus, or decreased hearing, which are most commonly inner ear problems, then I think we associate this migraine with the vestibular system, and that is called as vestibular migraine. In many of the publications, the vestibular migraine can be is a wide-ranging topic. It can be associated with a simple positional vertigo. It can be associated. It can be a type of a basilar type of migraine, or the classical vestibular migraine, which we will, I think, get to in the further, which we'll get to in the further discussion.
Very specifically, sir has told with the symptoms of some ringing or tinnitus and all, is what is a perspective of an ENT while looking to the vestibular migraine. I'll come to you, Dr. Ketaki, ma'am. As we know that migraine, one of the peculiar symptom of migraine is headache. So I would just like to ask you the question, does the vestibular migraine always feature a headache?
So if you think about a single episode, we would like to analyze it as a case. So most of the time the headache and vertigo coexist. So that's when we say it's a vestibular migraine. But not every time the vertigo is associated with the headache. So it can be associated with some of the classic migraine features like a visual aura, or there can be a photo or phonophobia, or there can be exertional worsening. However, most of the cases give a past history of headache, which is mostly like a migraine. Sometimes they would not go for a classical hemicranial migraine. They might have a common migraine, which is a holocranial type. But most of the times you would be able to find some or the other feature of headache. So both these symptoms are coupled. Vestibular migraine, the term itself suggests that. And like Dr. Rahul said, that when we have the classic oral features with a headache, either in the present or in the past, we would call it a vestibular migraine.
Exactly. Yeah. So very nice thing ma'am have told us. Yes, the visual auras or a phonophobia, photophobia, other symptoms can also be associated with this kind of headache. Yeah. My next question to Dr. Rahul sir. Sir, how would we distinguish between a vestibular migraine and some inner ear disorders? And also one more question added to this: how many patients come to you with such problem in your daily OPD practice?
I will like to address the second question first. As I said, migraine is a diagnosis of exclusion, and even a lot of publications state that vestibular migraine is a lot of times misdiagnosed or underdiagnosed. As Dr. Ketaki already said, that a headache is usually one of the most common features, but need not be present in all cases. So rather than me quoting how many patients come to me, I will quote the publications. There has been only one large study with respect to vestibular migraine. It was conducted in Germany, and they came up with the prevalence rate of migraine to be 0.98%. That is almost 1% in the entire population throughout their lifetime. 1% of the population will get it at some time. If you jot it down to maybe, again they said that it was again misdiagnosed a lot of the times and underreported as well. But if in a year, if you ask me, it is around 0.2% of the patients have vestibular migraine, which is quite low. That's what I will say. But again, this depends on how many patients actually present to us as ENT surgeons and how many are correctly diagnosed. Now, coming to the first question is, I think, very important, because arriving at a diagnosis in any vertigo patient is extremely important. And that is why we have stressed upon the fact, and we have started running a full-fledged vertigo clinic in our setup. And so basically, as in any case, history taking is the most important. You ask for history of headache, what are the associated features? Now, specifically, you asked about ENT, but if you ask me, in India, the most common causes of headache, I think if I jot it down, the first most common is hypertension, I think, but that is in the older population. Then second is refractive error. So your ophthalmic checkup should always be done. Thirdly, sinusitis. That is when the patients come to us. And lastly, if you ask me, then I will say it is migraine. I think Ketki may have a different say on this. So basically, firstly, you have to rule out all the sinus-related disorders when it comes to migraine from the ENT perspective. Next, if you go for the inner ear symptoms, as we already mentioned, those can be decreased hearing, unilateral or bilateral, tinnitus, oral fullness, etc. So in history taking, when you rule out all these conditions, I think you can safely start diagnosing it as migraine and gradually proceeding with the investigation. However, if any of these are present, then the diagnosis, the choice is between a vestibular migraine and any form of labyrinthitis. So that is the time when I will a complete ENT examination, checkup of the tympanic membrane, etc. is important. And a pure tone audiometry, I think, gives a very good indication in most of the cases. It is a very simple test. Again, so if you have a unilateral mild sensory neural loss, you can associate it with Meniere's disease, which will also have symptoms like oral fullness, episodic vertigo, and tinnitus as well. If you have any form of cervical neck pain or straightening of the spine, then you can associate it with cervical spondylosis. Then you have to rule out post-operative status in most of the cases, like an operated autosclerosis patients post-stapedectomy can have vertigo and headache as well, especially if it was a complicated case. Further down the line, you have other diagnoses like a non-specific viral labyrinthitis or idiopathic sensory neural hearing loss. So I think pure tone audiometry, if in children, a BERA may be required. And lastly, I think if you are not able to arrive at a diagnosis and want to term the patient as a vestibular migraine, I think an MRI brain is extremely important, because any cerebellopontine angle tumor or any space occupying lesion can have similar features to this. And once you have ruled it out, I think then you can term it as a vestibular migraine.
Exactly. So various conditions sir has explained us, whether this, if not then this, if not then this. So I think it is a very wonderful series he has explained us. I think it will be very important for us to mention it in our practice as well. My same question to you, Dr. Ketaki ma'am, but only the one question I have, one line I have changed, that what is the root cause of this vestibular migraine and the balance issues, and what is the number of patients coming to you with this type of problem? I think that
so the very reason why both of us are here is the connection between the nervous system and the ENT, or rather I would say the vestibular system. So basically the primary headaches are due to the trigeminal vascular system, and the vascular system which is associated with this trigeminal nerve contribute to the all the features of headache. So the labyrinthine vessels are supplied by the trigeminal nerves. So this is how the trigeminal nuclei and the vestibular nuclei are connected. So that's why, as we know, that headache is a spreading, like the aura spreads, it's a spreading phenomenon. So it can just be limited to the trigeminal system in the nociceptive areas of the brainstem, or it can go on to involve other nuclei in the brainstem like vestibular nuclei, and then involve the vestibular system. So this is how both these are connected, and then these have thalamocortical connections. So pain and then vertigo gets associated with each other. That's how I would say that this vestibular migraine happens. As long as balance is concerned, balance is usually it's a subjective feeling of imbalance. When we examine these patients, there are no hard signs, what we say. So balance is generally spoken in terms when there is inability to walk in a straight line. So these people are fairly able to walk in a straight line. They don't have any incoordination. They are able to perform activities on both sides quite equally. And most of the times we do not find any signs like nystagmus or very prominent hearing loss. So most of the times we are not able to find any localizing signs as such. Most of the things go in the history. We have to take a detailed history and do the examination to rule out anything serious. That's what I would say. So this is how the vertigo, imbalance and headache couples with each other. The second question which you said was, since being a neurologist, I see a lot of headache patients, and I would say like 20% of my OP cases are headache, and I think 10 or 12% cases seem to have vestibular migraine. But again, as you say that there are no hard diagnostic criteria, so the criteria are very not very clear, because there are 2 or 3 criteria. Some of neurologists prefer the ICHD criteria. I think ENT people prefer the Berenice criteria. So both of them have different terminologies, definition of vestibular migraine. So, and even the pathophysiology is not very clear. So I think so I think I see a little more cases of vestibular migraine, and as in in the last decade, vestibular migraine is being discussed and talked about more and more. So I think these days we are diagnosing it more.
Right.
It always used to be there.
Just one question. So you said 20% around of your cases have migraine or a headache of any sort, and 10 to 12% of them have vestibular migraine.
Yeah.
So it's around 1%. 1 to 2% of the total.
So if you take 100 patients of migraine, 10 or 12 might have a vestibular migraine. So to put it simply.
Yes. Okay.
Yes. So I think, ma'am, you have explained the pathophysiology very well, but yet the mechanism is hypothetical. So I think the stages and whatever the clinical manifestation we do in clinical practice is more important than what is there in the books, because this migraine is something very different from a normal perspective. I would like to come to you, Dr. Rahul sir, with a question that may I know the etiological factors basically that are responsible for the involvement of the inner ear problems, specifically exact cause of what causes this inner ear problems, specifically in the vestibular migraine patients?
As Dr. Ketaki has already stressed upon the fact that the trigeminal-vascular system is, I think, the most important etiological reason for the inner ear abnormalities which contribute to vestibular migraine. I think she will be able to better explain the nervous system involvement. What I will like to stress upon is you have to rule out, again, as I said, the other inner ear problems like Meniere's disease, otosclerosis, especially cochlear otosclerosis, or any retrocochlear space occupying region, cerebellopontine angle tumors, etc., or any sort of long-standing noise-induced hearing loss also. Because what happens, as I explained to my patients in very simple terms, the 8th cranial nerve, that is the vestibulocochlear nerve, has basically 2 sensations. One is hearing and the other is balance. And any sort of weakening of the nerve, be it a viral infection, be it a tumor causing pressure on the nerve, or be it the loss of cochlear nuclei due to long-standing noise-induced hearing loss or presbycusis, I think there will be associated vestibular symptoms as well as inner ear symptoms. The difficulty comes when this is coupled with headache. So that is when we should start looking at the vestibular migraine features.
Exactly. Very well explained by sir. Ma'am, I'll come to you. While explaining, you told us that this migraine is usually not in so good frame, we can say, or it is not into that light as it is required. So many times, in conferences, some statements are given, or we also say that vestibular migraine are always undiagnosed, or hence they are untreated. So what is your comment on this statement?
So I think until recently the importance of vestibular migraine was not stressed. It was always migraine with vertigo. So sometimes they used to call it migraine with vestibulopathy. Sometimes it was called as like a blanket, brainstem migraine. So we had such terms where it was not divided into proper categories. Now we have proper criteria. We know how this goes. Initially, some old neurologists and practitioners have shared in many conferences that they used to treat cases of headache. Then they used to have vertigo after 10 or 12 years. And then they used to have a lot of anxiety. They used to have too many other symptoms. And then they really thought that it's a functional overlap rather than a spectrum of the migraine. And they treated it that way. However, they prefer to continue the migraine prophylaxis, which worked for vestibular migraine also after adjustment of a few drugs. So I think as the neurology is evolving, vestibular migraine is gaining more and more important, and it's not as uncommon as it's discussed. And as you said that ours is a tropical country and most of the studies are reported from the Western world where they hardly see sun. So we have a lot of migraine cases, and since the load of migraine cases is so much, I think the percentage of vestibular migraine is also a lot.
Very important message ma'am has given, that yes, there is the possibility of having. The need is only to just have an exploration of vestibular migraine in those patients who are having a migraine. My next question to Dr. Rahul sir is, sir, may I know the exact symptoms of vestibular migraine in perspective of ENT, as we have discussed in earlier question also, but I think we can just have some of the symptoms.
The symptoms are, I think, already discussed. Basically, migraine means headache. That's what everybody of us will call it in layman terms. But before that, the most important thing is the aura. We have to talk about the aura. A lot of patients get this aura of migraine. So what exactly is the aura? Aura is the feeling that you are going to get a particular type of a headache. Maybe it may be associated with photo or phonophobia. It can be associated with mild visual disturbances. There can be a triggering factor like maybe some sort of food or going out in sunlight, especially in tropical countries, as Dr. Ketaki said. Then this aura usually lasts from 5 minutes to maybe about 60 minutes, and the symptoms are actually completely reversible. But I think a patient of chronic migraine always, I think, once he develops it 4 or 5 times, I think understands the aura of the migraine. Secondly, there can be associated nausea or vomiting also in certain cases. Some patients have associated reflux disease also along with this, as you call it acidity in normal terms, I think. And then we come to the vestibular symptoms, which I've already mentioned. First is giddiness. Secondly, it is unilateral sensory neural hearing loss, maybe. There can be oral fullness. There can be tinnitus or ringing sensation in the ear. But there again, you have to rule out all the middle and inner ear problems to come to vestibular migraine diagnosis. But I think aura, headache, and any of the vestibular symptoms, one or more, I think you can classify it as migraine. We won't get into exactly the definition because migraine involves 5 episodes with headache lasting for around from anything from 1 hour to 4. I'm jumbled up. So basically, any of the headache and vestibular symptoms, you can classify it as vestibular migraine if you rule out all the other conditions.
So exactly, both symptoms are being told by sir. I'd like to ask one question to Ketaki ma'am. While we were speaking, ma'am, you told that many a times earlier neurologist, you told that after 10 to 12 years, something related with anxiety or something. Some mental issues are also involved into the patients of this vestibular migraine. So I would just like to ask you the questions, ma'am. What is the role of different neurotransmitters specifically in vestibular migraine?
Yeah. So as we have already discussed the trigeminal vascular system, which is associated with headache and vertigo. So I'm not going to it again. Right, but this system is mainly the neuroinflammation which involves the vestibular migraine is actually because of CGRP, which is calcitonin gene-related peptide, and substance P. So the neuroinflammation is mediated by these 2 peptides. We have also seen that drugs which block these peptides also help migraine. So this is an indirect evidence. And the usual neurotransmitters which we know are serotonin, glutamate, norepinephrine, acetylcholine. So these are involved in the headache. I would not go into too much details because the interplay between these neurotransmitters actually precipitates the attack. So like we know some are excitatory like glutamate and serotonin, some are inhibitory like GABA. So they have an interplay with each other, and the imbalance between them leads to the headache, and these are the neurotransmitters involved.
Exactly. So very nice question, that some inhibitory as well as excitatory neurotransmitters are involved into this. As you all know that we have a cross talk, so I think debate is very important in this talk. So my very question to both of you, that earlier also we have discussed that it is a combination of trigeminal system as well as the vestibular system. So my common question for both of you, which is on the fault, whether it is ENT or a nervous?
I think we have discussed pathophysiology at length, and now we know that it's a connection between the two which is leading to the symptoms. Whoever the patient lands with gets treated.
I think treatment protocol is almost the same, so it doesn't matter.
Yeah.
So basically,
one question I will like to ask Kitki is, don't you feel, apart from that vestibular migraine and cervical spondylosis in mild to moderate cases can have a very similar presentation?
Yeah. So the cervical spondylosis people, like they won't have a migraine kind of headache. So unless it's migraine with cervical spondylosis we are talking about. And the dizziness in cervical spondylosis is very position specific, and usually in vestibular migraine it's not so specific as you get in BPPV or other cases. So they have a horizontal shakiness, a vertical shakiness, but the cervical spondylosis essentially it's because of neck flexion and extension. I would say hyperflexion and hyperextension, and that time they get symptoms. And the headache associated or neck pain associated with cervical spondylosis is a bit overdiagnosed, I would say. It is not as common as you would expect. Usually they have some kind of radicular pain in the limbs, upper limb, lower limb, or some radiating kind of neuralgic pain rather than a vague pain and imbalance. That's what I would say. And actually headache with cervical spondylosis is also classified as a secondary headache, and this is essentially a primary headache where really you don't get anything.
Early diagnosis and proper early treatment as well, I think it will be a very important tool to reduce this aggravating symptoms. My next question to Dr. Rahul sir, that I would just like to ask you that just like other migraine sufferers, is it true that vestibular migraine is also misdiagnosed as sinus headache?
I think a regular migraine is usually misdiagnosed as a sinus headache. I don't think a vestibular will be misdiagnosed. I will tell you the reasons. Mm-hmm. Usually when a patient comes to the ENT, especially in a tertiary care institute like us, the patient has already shown a couple of general practitioners outside, and I think any sort of headache, especially if it is associated with any of the nasal complaints, I think the patient gets told that it is a sinus related problem, and especially the unilateral headache. So when we examine the patient comes with mainly a headache problem, but then you have to be very meticulous in history taking and ruling out all the other factors. These days we are seeing a lot of the concha bullosa patients also presenting with unilateral headache. That is a pneumatized middle turbinate. But then again, that is not a sinus headache. That a pneumatized middle turbinate causing headache is a different chapter altogether. We also see the typical sinus headache will should have a sinus tenderness. So when we press the canine fossa for the maxilla or the frontal region, the patient usually winces in pain. So that is a frontal or a maxillary tenderness, we call it. A sphenoid sinusitis usually presents with occipital headache. So it can be misdiagnosed, but if you are very meticulous in your examination, I think you should come to a diagnosis whether it is a sinus headache or a migrainous headache. Vestibular migraine will also have vestibular symptoms. So there are more chances of misdiagnosis with any of the inner ear problems, or as I said, cervical spondylosis or a BPPV. But then again, with your proper history taking, I think a BPPV is a very transient headache associated with position, and it can last from a very few seconds to a few minutes. Meniere's disease usually has associated oral fullness and tinnitus and hearing loss as well. And again, as Ketaki said, all the cerebellar signs may be present in any of the cerebellar type of headache. So I think we can come to a diagnosis basically by proper history taking, examination, and investigations if required. But misdiagnosing it with a sinus headache, I don't think is much of a problem for us.
So the combination of perfect examination, diagnosis, and history taking can be the perfect trio for coming to the conclusion whether this patient comes to this category or not. My next question to Dr. Ketaki, ma'am. Ma'am, what can be the warning signs or red flags for this vestibular migraine?
So, I think the association of headache and vertigo together itself gives a clue that this is not a plain migraine or common migraine, what we call. Also, associated symptoms like aura, photo and phonophobia along with vertigo. These can be a little bit of, they can hint towards that, okay, this is going for a vestibular migraine. Also, some of the signs in vestibular migraine which we don't expect is like a profound hearing loss or an imbalance or unilateral signs in the ear. I think then we would literally think that there is something wrong with inner ear pathology, and we need to make Dr. Rahul see his ear and then rule out that is there something wrong. So yeah, vestibular migraine is not so bad that we have to see some red flags and get scared of it. I would say rather if we see these red flags, it's not vestibular migraine, it's something else.
So my same question to you as well. Is there any red flags from a perspective of ENT that the primary healthcare professionals should know so that they can completely directly refer to you?
I don't think so, because as Dr. Ketaki already said, that the symptoms are usually mild, especially in the early presentation. Even the headache or the vestibular symptoms are mild. We see even worse headaches in a lot of other conditions. And as an ENT, if there is any red flag, I think I will refer the patient to Ketaki first, because I will like to rule out all the neurological aspects, and then I will come to the EA. Because as an ENT surgeon, I don't think there is any red flag sign for vestibular.
Yeah, this is our usual drill, so we know what to do. Me and Dr.
So basically it is interconnected. This is a completely information for the viewers which are listening to us, that this is completely an interconnection between these two systems, and I think it is up to you what referral you have to go, but I think that is completely a fair from their perspective as well. Again, a common question for both of you that Dr. Rahul has already told us one small introduction as well. Are there any specific diagnostic tests for detection of this vestibular migraine?
Essentially, I would say that it's a clinical diagnosis. History and clinical examination is the thing. If clinical examination is not showing anything specific related to the cerebellar system or the vestibulocochlear system, also the history per se showing headache and classic features of migraine and vertigo, we would be comfortable to diagnose a vestibular migraine. So I think the symptoms are more subjective than objective. That's what I usually keep in mind, that these patients have a lot of subjective problems like headache, vertigo, dizziness, some rocking sensation, some instability, some fogging sensation in the brain. They just go blank sometimes. They have a lot of anxiety. There is mood disorder, sleep disorder. So always we see that in these cases, the symptoms are more than the signs which we see really on clinical examination. So that's how the usual approach is, that do the drill, do the history well, examine the patient in detail, and then you're good.
I think history is very important, because based on history, I think what clinical examination to do, I think we come to that. because you don't want to aggravate a headache just by doing any of the vertigo maneuvers or BPPV. So if you know that it's not maybe a vestibular migraine, just for the protocol you do a Dix-Hallpike, the symptoms may get aggravated. Or as I said, a cervical spondylosis patients can start having severe pain by doing all these maneuvers. So basically you take the history well, and then the examination will guide you to the diagnosis. You don't do the examination just for the sake of it. And that's what I said, because if you are diagnosing an inner ear problem, then of course the routine examination remains the same, but all the specific maneuvers or tests, I think only the history will guide you accordingly.
So I think on the bedside level we would do a head impulse, but nothing more than that to
recommended
confirm the test.
As an ENT, I will like do tuning fork tests and maybe a Puritan audiometry.
I think perfect history taking is only the tool for the perfect diagnosis and then the treatment. So my next question to Dr. Ketaki ma'am, what will be the line of therapy with perspective of neurological therapeutic management?
So like any other migraine, we can treat vestibular migraine with the drugs which are used for migraine prophylaxis. I would say that the drugs which work really well are beta blockers like propranolol. We can use SNRIs like venlafaxine, some tricyclic antidepressants, or selective serotonin reuptake inhibitors, so sertraline. So these are the drugs which we commonly use. We can also use amitriptyline, imipramine. So these drugs also work well. Sometimes in like serious cases when there is an attack per se, in 20-30% cases they do well with the triptans as well. So sumatriptan or rizatriptans can be used. Sometimes they present as a very acute phase, which we call as status migrainosus. So in that case, steroids also are useful in oral or intravenous form. So they can bring down the headache by 60% in an hour or so. So in that case, I think one would like to use a steroid. Prophylaxis per se, we can also use CGRP monoclonal antibodies, which are available these days, and they are really useful in a refractory kind of vestibular migraine. So first, I think the protocol is go with the good old usual primary prophylaxis medicines. I forgot to mention about some calcium channel blockers as well, which we know that flunarizine responds very beautifully. The common migraine as well. Also the vestibular does respond. So it's up to you. Then after a while you get a hang of it after a clinical practice, that which works well. Does this patient have any additional mood disorder or sleep problem, so that you can select the drug accordingly. The favorable side effects of a particular drug can work for the patient. So it will be customized according to the patient really.
Exactly. Very well explained, that use of conventional therapies and then again the novel therapies which are emerging nowadays, and combination of, we can see, the personalized things can be a better option for treating this disorder. My same question to you, Dr. Rahul sir, that what can be the possible treatments from your perspective, and also we would like to know about some non-pharmacological therapies if available for this vestibular migraine.
So basically, for any vestibular problems, I think the treatment protocol almost remains the same. The drugs may change. So firstly, I think we'll go for lifestyle modification. The patient should have good diet, regular timings of meals, good sleep, to reduce his alcohol content or stop smoking, whatever it is. Weight reduction is again important. Secondly, as Dr. Ketaki said, we need to treat the headache by analgesics. I think as an ENT we start with the simpler ones with NSAIDs like ibuprofen or maybe diclo, and gradually we step them up. Then the triptans for chronic migraine patients, maybe for long-term use. What I like to highlight is the labyrinthine suppressants for the vestibular symptoms. So prochlorperazine or cinarizine for acute vestibular symptoms, they work very well, I think, and they reduce the vertigo immediately. For chronic cases, I think beta histine works well. and you give it gradually in tapering doses. Because what happens is basically the main pathology remains the vasoconstriction of the vessels, maybe in the around the trigeminal vascular system, and I think these drugs help in the vasodilation and increasing the good blood supply to the inner ear. So chronically we use usually a beta histine, and most of the time these patients may have nausea and or vomiting. So we will like to give a domperidone associated a domperidone along with them. So a lot of these drugs are given in combinations. Then for prophylaxis, I think Ketaki said that you use a beta blocker for treatment, but I think ENT studies show that propranolol helps in prophylaxis of this type of migraine.
Yeah,
but I'm not very sure,
prophylaxis.
and we don't use it much, honestly.
Yeah.
And then coming to the non-pharmacological therapies, I think the most important one is vestibular rehabilitation exercises. If you have diagnosis it as BPPV, then it's different. We go for the Epley's maneuver and all those sort of things. But I think we will stick to vestibular migraine or any of the vestibular problems. Then there are simple vestibular rehabilitation exercises. We give a chart to the patients and they are asked to do head, neck, posture exercises. If not, they are not doing it themselves or unable to do it, or the vestibular symptoms are getting aggravated, then I think we'll refer the patient to a physiotherapist and get the proper exercises done. Some studies show acupuncture helps, but I am not of that view at all, so I won't recommend it. And I think that's about it. So dietary modification, physiotherapy, I think are the non-pharmacological management options, and leading a good healthy lifestyle always helps in all cases.
Yeah, I would like to actually after this discussion ask Dr. Rahul that do you recommend to use beta histine or other labyrinthine suppressants in a chronic form? Because
so basically the protocol we follow is cinnarizine is usually given for the acute patients, and we may add a prochlorperazine, which are mouth dissolving tablets, especially if the patient travels frequently or stays alone. Then I think that helps quite a lot. Okay. And that is usually coupled with a pantoprazole along with domperidone. Okay. But what we see is the acute phase of the vertigo reduces, and sometimes patients don't follow up at all. And then if they come back after 1.5 or 2 months, again the vertigo has started. So we make it a point to counsel them that after the initial 5 to 10 days of the acute phase getting reduced, we start with a beta histine, usually 16 milligram 3 times a day, then twice a day, and then once a day, maybe for in 7 days or 10-day periods, and gradually to taper it down in a month's time. I think that way the vertigo symptoms gradually subside, and by that time the exercises kick in, and I think we insist on the patient doing good exercises, and I think that way the postural balance is maintained, and patient is able to have a long symptom-free period. But again, we always make sure, as you also know, that the vertigo will never go away completely, and it can recur at any time. So the patient always has to be aware of that.
Yeah. So what are studies usually I've gone through the studies in neurology journals. What they recommend is, since this has a completely different physiology compared to the positional vertigo, where we would like to use a long-term labyrinthine suppressants, we have to give a prophylaxis drug for this kind of migraine, because in the long run they are going to have attacks. So to bring down the attacks, really we have to give a prophylaxis medicine which will take care of the connections and the projections from trigeminal nerve to the vestibular nerve. So until that is taken care of and the nociceptive receptors are brought down with the prophylaxis, I think this will keep on happening. So what I would suggest is like a short-term care for the vertigo with some labyrinthine suppressants, and in a long term, I think instead of repeated use of these drugs, good prophylaxis medicine will work and take care of headache also. So both headache and vertigo will settle.
True. I wouldn't classify beta histine as a labyrinthine sedative. Basically, it's a vasodilator in the inner ear.
Yeah.
But as you said, I think propranolol or as you said, SSRIs help quite a lot in these cases.
Yeah.
And there is no harm in adding them to the prophylaxis of these patients so that they can have a good symptom-free period.
Yeah.
Longer symptom-free period.
Yeah.
My very last question to the discussion which we had done. Actually, sir has told the proper therapy, ma'am. What should be the duration of treatment for long-term prophylactic therapies?
Yeah. So it's a very debatable question. So depending on how the patient presents to you. So if the history is very short, say for a 3 to 6 month period, we would usually target to give a prophylaxis for 6 months to 1 year. However, most of the patients are chronic migrainous, so they might require a very long-term therapy. So it can range from 1 to 2 years, or maybe we have to go till 5 years also. So depending on how the patient responds, if there is a symptom-free period for 3 to 6 months, then I am comfortable enough to reduce and taper off the prophylaxis, and then only keep on NSAIDs as and when required. As and when there is headache, the patient can take NSAID. As and when there is a mild dizziness or vertigo, the patient can go for simple drugs or labyrinthine suppressants. But there should be a significant interval where there's no headache, there's no vertigo, the patient is absolutely okay. And most of these patients have motion sickness also. So the symptoms are triggered by motion, traveling. So all in all, they are known to recur. So a little bit of longer prophylaxis than what I would give for a common migraine. However, if there is a pain-free and vertigo-free period, definitely it has to be tapered off, and we can take the patient off medicines.
Exactly.
I have 2 questions for Dr. Ketaki.
Yeah.
Firstly, going a little off topic.
Yeah.
Will you recommend a MRI in all these cases, or what is the point at which will you recommend an MRI? And secondly, what is the role of opioid analgesics in these cases?
Yeah.
Is there any role?
So MRI I would not recommend unless I am seeing any red flag in the headache and vertigo pattern. So after seeing so many patients of vestibular migraine, you just get to know that there are no localizing signs, there are no lateralizing signs, there are no hard signs to suggest any other cranial nerve involvement. There is no vision loss, there is no impairment of swallowing, there is no sensory loss, the limb movement, power, coordination, everything is good. Then I won't recommend MRI for this patient. It's a purely clinical diagnosis and we can go ahead.
If symptoms don't get reduced by maybe 1 or 2 courses, then will you recommend?
Yeah. So if there is any evolution in the headache, then MRI might be recommended. But if there are no signs, because mostly the MRI is going to be normal, or you can see some non-specific white matter changes in the subcortical area. So those are the findings which you usually get. So unless you are sure that this is something else and it's not vestibular migraine, then imaging is really recommended. The second question. Yeah,
just to interrupt, I think what I'll suggest is, in this day of medico-legal problems, if my patient is happy, is only symptom-free for the duration of the treatment, and then again the symptoms recur, I think after a couple of courses, I might recommend a MRI just to be sure, because later on you don't want to land into a problem of a misdiagnosis or an underdiagnosis.
So this is apart from our academic discussion. This is something we would do in our common practice.
Second question.
So second question is opioids. Yes, in acute attacks, sometimes you have to use opioids. Opioids, they also respond very beautifully to opioids, but only in select cases. So in some cases who have a very bad headache, per se, for the headache, I would use an opioid, not for
Which is the preferred one for migraine as a neurologist?
We would use a tramadol.
What about
otherwise, as a long term, we do not prescribe because they just keep on taking it.
Okay. What about naproxen?
We use that. So in the combination with some pantoprazole or domperidone, we can use that.
There's a lot of I see in a lot of if the patient is already considered a neurologist, I think most of them are taking naproxen. That is specifically what I wanted to.
It's like bias.
Yes.
Yeah, I have also seen many patients keeping naproxen and domperidone always in their pocket whenever they. Yeah, so that is what is, I think, a good drug.
Yeah, it's the SOS drug.
Yeah.
It's not you shouldn't it shouldn't be considered as a good drug. After all, it's an opioid, and you have to be very judicious in prescribing it.
Otherwise, they just keep on popping it all the while.
It's addictive.
Yeah.
So I think one more session on awareness related on drugs also we should keep to just have discussion on this as well, because it is also very needed. Because we have seen this practice in urban areas a lot, even in the remote areas. So I think putting a perspective on this is also very important. Yes, so it was completely a great discussion with the expert duo, as I have told earlier also, that this completely a system, like completely this disease is a combination of these two systems, that is trigeminal vestibular. And I think we have beautifully explained, both of our faculties have beautifully explained the perspective, right from what it is, what are the etiological factors, what is the pathogenesis, pathophysiology, what can be the diagnostic, what are the red flags, and what should be the line of therapy, the acute as well as the chronic, also short term as well as the long term. So I think this was a completely a great package to know what exactly is the vestibular migraine, and we are very fortunate to have Dr. Ketaki ma'am and Dr. Rahul Gosavi sir on this platform to discuss on this untouched topic. So again, I would thank you a lot for giving us a wonderful time for this discussion, and we'll be always looking for more such discussions in future, because this disease is something what is to be discussed on platforms as much as you can, so that we can create an awareness for this topic. So again, I thank you a lot. Thanks both of you a lot for giving us your valuable time and coming to our session. Also, I thank all the viewers who are viewing to us, and I would like to I request them to like and share as much as you can, to just know and create awareness for this topic. Once again, I thank every one of you.